Welcome everyone to Health for the World International Grand Rounds. We are really honored to have our Grand Round speaker, Dr. Jessica Kurian, who is an associate professor of radiology and pediatrics at Montefiore Medical Center and Albert Einstein College of Medicine. Dr. Kurian graduated with honors in pathology from New York University School of Medicine in 2006. Following graduation, she became an intern in internal medicine at Caritas Carney Hospital. Dr. Kurian then completed a residency in diagnostic radiology at Albert Einstein and followed by a fellowship in pediatric radiology at Children's Hospital of Philadelphia in 2012. Dr. Kurian's research focuses in pediatric radiology. Her original work has appeared in reviewed books, reviewed journals, books, abstracts, posters, and exhibits. Dr. Kurian's work has received recognition at the annual meeting of the Society of Pediatric Radiology and also the annual meeting of the Radiological Society of North America, which is the RSNA. She is a member of multiple professional societies, including the Society for Pediatric Radiology, the American College of Radiology, and the RSNA. We are really honored to have Dr. Kurian give the grand rounds on a very important topic, which is imaging of pediatric pneumonia. Thank you so much, Dr. Kurian, and you can start whenever you are ready.
Okay, thank you so much for the introduction, and thank you all for having me. I'm very happy to be talking to you today about the imaging of pediatric pneumonia. So pediatric pneumonia, what is it? It's the broad term for infections of the lower respiratory tract, and it's the leading cause of death in children worldwide. It's the most common indication for imaging of the chest. So what causes it? It can be caused by bacteria, viruses, and fungi. In children after the age of 5 years old, bacteria is most common, and the most common organism is Streptococcus. In children under the age of 5, viruses is the most common cause, although bacteria is still important in that age group. Multiple organisms often coexist in a single infection, and in many cases, the proof of the organism cannot be obtained. So over the last 20 to 30 years, there's been change in the landscape of pediatric pneumonia, and this is due to the introduction of conjugated vaccines for Haemophilus influenza B and pneumococcus. This has led to decreased incidence of pneumonia, hospitalizations, complications, and mortality. At the same time, there's been a shift in the causation of pneumonia where viral pathogens become more predominant. However, the vaccines are also effective in reducing the complications of viral pneumonia because the most common complication is actually a bacterial pneumonia. So for children who develop pneumonia early in their life, or if they have severe or recurrent episodes of pneumonia, there are several health risks. Some of the chronic sequelae include restrictive lung disease, obstructive lung disease, bronchiectasis, chronic bronchitis, asthma, and there's a possible link to adult COPD. So as you can see, it's very important to diagnose and manage pediatric pneumonia early to try and prevent negative long-term health outcomes. The diagnosis of pneumonia is made primarily on clinical findings, and the most important clinical findings are cough, tachypnea, and shortness of breath. Other things that can be seen are retractions, abnormal physical exam, fever, and hypoxia. So chest radiographs are obtained to confirm the diagnosis. They're not needed in all cases, especially for cases of mild pneumonia, but they may be obtained in patients with more severe symptoms or patients who are going to be hospitalized. However, a chest radiograph cannot always tell you whether you're dealing with a viral or a bacterial infection. So it really has to be used in conjunction with the clinical findings and the lab data. So this is a brief outline of what I'm going to try to cover today. So I've divided this into two sections. The first is going to be about community-acquired pneumonia, And in this part, I'm going to talk about the differences between bronchiolitis and pneumonia, and then imaging of pneumonia and its complications. And then in the second part, I'm going to touch briefly on some special groups, including patients with TB, immunocompromised hosts, and I'll speak briefly about COVID-19 pneumonia. So pneumonia is a very broad topic, and I'm just going to be talking about things that we see commonly in our clinical practice. I hope this will be helpful for you as well. So let's start with the community-acquired pneumonia. And I'm going to be showing you cases all throughout this lecture to try to reinforce some of the points. So our first case is a 20-month-old who came in with fever and cough, and we have a chest x-ray that shows that the lungs are hyperinflated, the diaphragms are a bit flattened, and the heart looks like it's perched on top of the diaphragm. Also, the patient has these streaky perihilar opacities on both sides, and they're fairly symmetric, and there's no focal or lobar consolidation, and there's no pleural effusion. So this is an example of viral bronchiolitis. Bronchiolitis is an infection of small airways or bronchioles. The most common age, or the peak age group, is 2 months to 2 years, and the symptoms are coryza, cough, tachypnea, wheezing, and crackles. The most common cause is respiratory syncytial virus, or RSV, and the second most common cause is rhinovirus. However, there are many other viruses that can cause bronchiolitis, such as parainfluenza, metapneumovirus, adenovirus, influenza, coronavirus, and bocavirus. So in bronchiolitis, there's inflammation and edema, which causes obstruction of small caliber terminal airways. This leads to air trapping, which we see on chest x-ray as hyperinflation, and mucus plugging, which we see on chest x-ray as segmental or subsegmental atelectasis. So on chest x-ray, sometimes hyperinflation can actually be the only finding in viral bronchiolitis. Other things you can see are peribronchial thickening, perihilar opacities, atelectasis, which can be patchy and mobile. The findings are bilateral, and there's no pleural effusion. For hyperinflation, usually we just kind of eyeball it, but if you're not sure if the lungs are hyperinflated, there's some things you can look for. So you can look for flattening of the diaphragm, and that should be present on both the frontal and the lateral. You can count the anterior ribs on the frontal view, and more than 6 anterior ribs is hyperinflation. So this example has 7. The heart looks like it's perched on top of the diaphragm, meaning there's no heart overlapping the diaphragm. And if you do a lateral view, you may also see increased retrosternal clear space. For peribronchial thickening, it's manifested as linear or band-like opacities and peribronchial cuffing. And peribronchial cuffing is when you see the airway in cross-section because the wall is thickened. So it looks like little donuts on the chest x-ray. And normally it's okay to have 1 or 2 donuts, but you shouldn't have too many. These are 3 different cases of RSV bronchiolitis, just to show you the patterns that you can see. So in the first one, the lungs aren't hyperinflated, but we do have these symmetric, hazy perihilar opacities. In the second one, this patient has peribronchial thickening. So you can see lots of little donuts in both lungs. And then in the third one, the lungs are hyperinflated. We see that the diaphragms are flat, and there are multiple areas of linear atelectasis on both sides. So a common clinical dilemma is when you have an infant or a young child and you're trying to determine whether they have bronchiolitis, viral bronchiolitis, or a bacterial pneumonia. Both can occur in the younger age group, and they have overlapping clinical features. And this is a place where chest x-ray can be helpful in excluding a bacterial pneumonia. So our next case is a 4-year-old male who is otherwise healthy but is presenting with fever and chest pain. So on the chest x-ray, we have a retrocardiac or left lower lobe dense opacity, and we can see air bronchograms, which are these lines, lucent lines, and those are the airways which are being outlined because the alveoli around them are filled. So air bronchograms are a sign of an alveolar process, and that's seen in pneumonia. So this is an example of lobar pneumonia. Lobar pneumonia is usually a bacterial infection, and there are some authors that call it acute focal pneumonia. And I think the reason they call it that is because it's usually focal, meaning it's in one lobe, as opposed to viral infections, which have multiple opacities, so they're non-focal. So that distinction can be helpful in trying to distinguish viral from bacterial. However, just remember that both of those patterns can be seen in either type of infection. The most common cause of lobar pneumonia is Streptococcus pneumonia. Other causes include Hib and Klebsiella pneumonia. And oftentimes there are multiple organisms that are interacting sequentially or concurrently within a single infection. The presentation includes cough, tachypnea, fever, toxic appearance, pleuritic chest pain. And interestingly, it can present with abdominal pain in children. In lower lobe pneumonia, you can have pain referred from the diaphragm to the abdomen, and it can be mistaken for an acute abdominal condition. On a chest X-ray, the findings are a dense opacity or an alveolar consolidation. It can be segmental, lobar, or round. You'll look for air bronchograms. You may see a silhouette sign, which is when you lose the margin of a normal intrathoracic structure because of an adjacent pulmonary consolidation. There can be bulging of the fissures and often a pleural effusion. So this is the case of pneumonia that I already showed you, and I wanted to show you the lateral view in this patient. This is a spine sign. So normally on a lateral view, when you course down the spine from top to bottom, the vertebrae look more lucent. But in this patient, as we go from top to bottom, it actually becomes more dense. And that's because there's a pneumonia in the left lower lobe. This is an example of a right upper lobe pneumonia. So here we have an opacity, which is abutting the minor fissure on both views. This is a right middle lobe pneumonia with a silhouette sign. So there's an opacity here in the right middle lobe, and it obscures the right heart border. And on the lateral view, it's overlying the heart. This is a lingular pneumonia with a partial silhouette. So here's the left heart border, and then when we get here, we lose it because there's a consolidation in the lingula, and it overlies the heart and abuts the major fissure on the lateral view. And then here's a patient who has a multilobar pneumonia. So we have opacities in the left upper lobe and in the lingula and in the left lower lobe. And there's an air bronchogram here in the left lower lobe. Our next case is a 3-year-old male who is otherwise healthy and is presenting with cough. And on the frontal chest X-ray, we see there's a well-defined nodular round density in the right upper lobe. And on the lateral view, it's in this area, but it looks a bit less nodular on the lateral view. This is an example of a round pneumonia. So round pneumonia occurs in children before the age of 8 years old. And it's confined to this age group because the lungs are not yet fully developed until you're 8 years old. So the collateral pathways of collateral air drift are not fully mature. So this limits the spread of infection. And so the pneumonia takes on like a round and nodular shape. The most common cause is strep pneumonia. On chest X-ray, it's usually a solitary spherical opacity with well-defined borders. It's located in the perihilar regions or in the posterior regions. On the lateral view, it's usually less mass-like. And this is a case where follow-up radiographs in 2 weeks should be obtained to document resolution. In any other type of lobar pneumonia, you don't need to do follow-up radiographs if it's an otherwise healthy child. So I've shown you several findings of viral bronchiolitis and bacterial pneumonia on chest x-ray. So how good is the chest x-ray actually? It's still considered the gold standard for defining a pneumonia event, but the routine use of chest x-ray is actually controversial. In our practice, we consider it to have a pretty high negative predictive value. So that means that if there's no focal consolidation, we have presumed that the patient has a viral infection and they are not prescribed antibiotics. However, the positive predictive value is pretty low. When you have an opacity on a chest x-ray, we're not very good at saying that it's viral or bacterial, and this probably leads to overprescription of antibiotics. I wanted to mention briefly some newer advances in the diagnosis of pneumonia. There are two modalities that are being explored as first-line imaging. One is ultrasound and the other one is MRI. The reason for interest in these two modalities is that they have the potential to completely avoid radiation exposure. Although I should point out that the radiation exposure from just a single chest x-ray is actually pretty low. So ultrasound is being used in the point of care setting in the EDs or clinic for screening for pneumonia. What you can see is in the subpleural regions, you can look for consolidation, but ultrasound is limited to that part of the lung. Ultrasound is not very good at distinguishing atelectasis from pneumonia. So we need further study on this to see whether it actually changes patient outcomes. This is an example of pneumonia on ultrasound in a 4-year-old boy. So here we have a subpleural wedge-shaped consolidation. There's partial loss of the pleural line, and there are these dots and lines which represent air bronchograms. So currently, the established use for ultrasound of the chest in infection is to identify pleural complications of pneumonia, which are parapneumonic effusion and empyema, and I'm going to talk more about this shortly. The second newer technique is rapid sequence MRI of the chest. This is done as a non-contrast exam with focus on T2 weighted images. On T2 weighted images, pneumonia will appear as a high signal area of abnormality, like it does in this case. This is a right upper lobe pneumonia, and it has a corresponding chest x-ray with a right upper lobe pneumonia. So there are very limited studies on this topic. However, I think it's a promising tool for patients who have chronic conditions, for example, cystic fibrosis and immunocompromised patients. Those patients may be subject to multiple repeated CTs over their lifetime. The limitations of MRI are susceptibility artifact, lower spatial resolution. We have to consider the age of the patient and whether they can cooperate because the exam is very prone to motion. And if patients need sedation or anesthesia, those can induce atelectasis, and it can be hard to tell the difference between atelectasis and pneumonia. So our next case is a 2-year-old girl with pneumonia who was not responding after 6 days on antibiotics and a chest tube. So on her chest x-ray, we see there's a lot of opacity in the right chest. We have consolidation in the mid and lower lung fields, and we also have a large pleural effusion. So the patient had a chest ultrasound to get a better look at that pleural effusion. And what we see is that there is this consolidated lung, and it's surrounded by a large pleural effusion. And the pleural effusion is very complex. It has lots of lines in it, and those represent septations and fibrin strands. And it's also got a thick rim around it, and that's called a pleural rind. So these are all findings of empyema. So this case is going to transition us to the complications of pneumonia. So these are divided into pleural and parenchymal complications. The pleural complications are parapneumonic effusion and empyema. The parenchymal complications are cavitary necrosis, lung abscess, pneumatocele, and bronchopleural fistula. So we're going to go through all of these, and we're going to start with the pleura. A paramnemonic effusion is defined simply as a pleural effusion adjacent to a pneumonia. It's pretty common in about half of the cases of pneumonia. It can be either simple or complicated, and complicated means that the infectious organism is present in the pleural space. However, both types can be anechoic or black on ultrasound. So this is an example of a paramnemonic effusion in a 9-year-old girl who had a left lower lobe pneumonia. So here we see a large pleural effusion on the left, and on ultrasound we see large amount of fluid which is completely black or anechoic. So this is a paramnemonic effusion that is simple appearing. Empyema occurs when a paramnemonic effusion progresses to a thick, purulent pleural effusion. It's essentially having pus in the pleural space. It's much less common, and it's actually become even less common since the development of the pneumococcus vaccine. And it's frequently associated with underlying necrotizing pneumonia. On ultrasound, empyema is loculated, and loculation really refers to the shape. It has an internal convex border against the lung, or a lenticular shape. It's echogenic, so instead of being black, it will have echoes floating in it, and you can see fibrin strands, septations, and a fibrinous pleural rind. So this is a 1-year-old boy, and he has a pneumonia in the lower lung field on the right, and he also has a large pleural effusion, and the pleural effusion has this shape where it's convex internally against the lung. And on ultrasound, we see that the effusion is very complex. So instead of being black like the previous case, it has a lot of tissue in it and these lines, which are fibrin strands. And he also has a thick rim around the effusion, and that is a pleural rind. So ultrasound can be helpful in distinguishing consolidation versus effusion. And this is very important when you have a chest x-ray where there's a whiteout on one side, and you're not sure how much of it is fluid and how much of it is lung consolidation. So the things you look for in a consolidation are hepatization of the lung, which is a liver-like appearance of the lung, air bronchograms, and the presence of Doppler flow. So these are all things that help you know that you're dealing with consolidation instead of fluid. So this is a chest x-ray in a patient who has a big right upper lobe pneumonia and a small pleural effusion. On the ultrasound, we see the pleural effusion at the base of the chest, and it looks simple. It's very black. And when we pass through the upper part of the chest, we actually see the pneumonia. So we have a large area of solid appearing tissue or liver-like tissue, and it has these lines in it, these bright lines, and those are sonographic air bronchograms. This is another case in which ultrasound was helpful in determining whether you're dealing with lung or pleura. So here we have a near complete whiteout of the left chest, and there's mass effect with deviation of the trachea towards the right. And on ultrasound, we see that most of this opacity is actually a very large, high-grade effusion with lots of fibrin strands and lots of septations. So this was a big empyema. So CT is very poor at differentiating effusion from empyema because the septations and debris cannot be seen. They're below the resolution. Some things that you can see on CT are loculation or lenticular shape, which is what we see in this case right here. This patient has an empyema on the right, and we have multiple lenticular fluid collections in the pleural space. The split pleura sign is when there's enhancement and thickening of both the visceral and parietal pleura. And there can also be infiltration of the extrapleural subcostal fat. This is an ultrasound from the same patient as the previous CT. And here you can see that we get a lot more of the detail of the empyema. So we can see all of the septations, and we can also see the pneumonia. So here there's an area of hepatized lung with air bronchograms and Doppler flow. This is a CT from the chest x-ray of the first case of empyema that I showed you. So in this patient, you can see a lenticular shape of the pleural fluid. And if you look a little closer, we can actually see the pleura, the parietal and the visceral pleural enhancing on both sides of the effusion. And that is the split pleura sign. So I've shown you the ways that ultrasound can be very helpful in assessing pleural complications of pneumonia. You can characterize the pleural fluid and you can distinguish effusion from consolidation. So ultrasound is helpful in guiding the management of these complications. For an uncomplicated effusion or parapneumonic effusion, the treatment is antibiotics with or without a chest tube drainage. For an empyema, the treatment is intrapleural fibrinolytic therapy or TPA versus a VATS, video-assisted thoracoscopic surgery with a decortication. Now, in the past, the choice between TPA and VATS was usually based on your institution. However, now there is definitely a trend towards preferring TPA as a non-surgical way of treating empyema. Please note that ultrasound does not necessarily predict the outcome or the need for surgery. So our next case is a 20-month-old female with pneumonia. So on the first chest x-ray, there's a large consolidation in the right upper lobe, and it's bulging the fissure inferiorly. On this chest x-ray, which was done 6 days later, we see that within that consolidation, now she's developed these irregularly shaped lucencies. And these are not normal lung. They're irregularly shaped and they're very black. And this is an example of necrotizing pneumonia. So now we're going to move on to the parenchymal complications of pneumonia. And we're going to start with cavitary necrosis. So in cavitary necrosis, you have fluid or air-filled cavities with loss of normal lung architecture. On a chest x-ray, you can only see it after the spaces fill with air. On CT, you'll see poor parenchymal enhancement, and on color Doppler ultrasound, the areas of necrosis will be avascular. So here's the same patient with the right upper lobe necrotizing pneumonia. And she had a CT scan, which shows a large area of necrosis in the right upper lobe, which is fluid attenuation with multiple lucencies in it. This is a different patient who has a right lower lobe pneumonia. There's an internal lucency with possibly a meniscus. And on the CT for this patient, we see that there's these rounded areas of decreased enhancement within the right lower lobe pneumonia with small lucencies. So this is another example of cavitary necrosis. Sometimes you can see it on ultrasound. Even if you were looking for the pleura, you may catch cavitary necrosis in the lung. So this is an example in a 2-year-old male. I have multiple ultrasound images which show that there's this consolidated lung. There are air bronchograms, and then there are these hypoechoic spaces. Some of them are kind of large and almost look cystic. And on color Doppler, those areas are avascular. This is a CT scan in the same patient. This was done a few days later, and we see this very large area of cavitary necrosis with irregularly shaped lucencies. Now, a lung abscess is the progression of cavitary necrosis. In an abscess, you have a collection of pus in the lung, and on imaging, you'll see a fluid and air-filled cavity with a well-formed fibrous enhancing wall. So in this example, we have a right upper lobe consolidation with a lucency, and on the CT scan, we can see it's actually a thick-walled cavity with air and fluid and an air fluid level. This patient also has mediastinal adenopathy. This is another example. Again, on both the chest x-ray and the CT, we see a thick-walled cavity, and on CT, we can see an air fluid level. Again, there are some enlarged lymph nodes here. Now, pneumatocele is a thin-walled, air-filled cyst that probably represents a later or resolving stage of lung necrosis, and it can appear as early as 1 week into an infection. Staphylococcus aureus is the most common organism. So this is a 3-year-old boy who has a right upper lobe pneumonia. This is a chest x-ray 10 days later, and we can see that the pneumonia has cavitated. Now there's an internal lucency. And then this follow-up from 45 days later, we see that his pneumonia is completely resolved, and all that's left behind is a small thin-walled cyst. So this is a pneumatocele. This is another example of how necrosis can progress to a pneumatocele. So here we have a right upper lobe opacity with bulging of the fissure and an air fluid level. So this is actually a pulmonary abscess. Within 7 days, a lot of the opacity has cleared. It's more lucent and expansile. And at 23 days, we see there's a large air-filled thin-walled cyst. So that's a pneumatocele. Pneumatoceles usually resolve within 3 months. However, they can persist and become reinfected, and they can also rupture and lead to a pneumothorax. A bronchopleural fistula, this is going to be our final parenchymal complication. This is when there's a communication between the lung or airway and the pleural space. The hallmark finding on imaging is air in the pleural space, and on CT, you may be able to define a fistulous tract. So this is an example in a 20-year-old woman. This patient had very severe bilateral pneumonia with necrosis in the left lower lobe. And on her CAT scan, we can see she has a large left pneumothorax with an air fluid level. And on the coronal image, you can see there's a communication between the left lower lobe and the pleural space. All right, so believe it or not, we've covered the first part of my talk, and now we're going to move on to the special populations. I'm going to start with this case, which is an 11-year-old boy with chest and back pain who was treated for pneumonia 3 months ago. So I'm showing you CT scan on lung and soft tissue windows. He has a consolidation or pneumonia in the middle and lower lobe. And also in his right lower lobe, he's got extensive tiny nodules. And on the soft tissue windows, he has a destructive lesion of a thoracic vertebrae with a paraspinal abscess. This was a patient with disseminated tuberculosis. So there are 3 forms of tuberculosis: primary, progressive primary, and reactivation or post-primary. In children, the hallmark finding of primary tuberculosis is hilar and mediastinal lymphadenopathy. Other things you can see are parenchymal lesions, which can be single or multifocal. Over time, the lymph nodes and the parenchyma can cavitate and later calcify. The lymphadenopathy can be quite significant and cause narrowing of the bronchi, and this can lead to air trapping and collapse. Pleural and pericardial effusions can be seen, although those are less common. This is imaging from a 2-year-old girl with primary tuberculosis. On her chest x-ray, we can see there's widening of her right paratracheal stripe, and this is due to mediastinal lymphadenopathy. And there's also an opacity in the right middle lobe. And on her CT scan, she has subcarinal and hilar lymph nodes, which are centrally hypoattenuating, meaning they're necrotic. This is another example of necrotic lymphadenopathy in a 12-month-old boy with primary TB. So here we see these large lymph nodes, which are low density with a peripheral rim, and they're actually narrowing the pulmonary arteries left more than right. Now, progressive primary TB is when the primary complex becomes progressively larger and liquefies. It's actually rare, but it's more common in the younger age groups. There are 2 ways that primary TB can spread to become progressive primary TB. So in the first form, the primary complex ruptures into the airway. And this is called bronchogenic or endobronchial spread of disease. And on CT, it looks like a tree in bud nodular pattern. The second way is for it to spread through the lymphatics and the bloodstream. And this leads to miliary nodules on CT. And this can be seen not only in the lung, but it can spread to other organs, including liver, spleen, brain, and the spine. This is an 11-year-old boy who had primary progressive TB. So on the coronal CT image, we have a pneumonia at the right base. We have necrotic lymph nodes in the mediastinum. And on the axial lung window, we see there are a lot of tiny nodules in the right lower lobe. Now, if I zoom in on them and try to look at the pattern, you can see that they have a tree in bud pattern. So this is endobronchial spread of TB. Now, this is an example of miliary disease. This is a 14-year-old boy with anemia and weight loss. And on the CT scan, we can see that there are innumerable tiny nodules in both lungs. Now, if we zoom in on this one, we can see that the pattern is random. So this is miliary or random pattern of nodules. On the next CT, there are necrotic lymph nodes in the left cervical region, and this was miliary TB.
Dr. Kurian?
Yes.
Can I have you answer two questions from the audience here? There's one from 9:20 a.m. regarding use of ultrasound for pneumonia evaluation. If the consolidation is more medial and central, how easy will it be detected?
That's the limitation of ultrasound. It's really good for the subpleural regions, but not good for the central regions. So I think the smaller the patient, the more likely you are to see it, but that's definitely one of the known limitations.
One more question from Enrique at 9:30. What do you think about the overexposure chest radiography in the children?
What do I think about it? I don't know how it is in other countries, but I think it's definitely overutilized here. You know, it's the WHO guidelines actually say you don't need to get a chest x-ray in patients who have mild respiratory symptoms. You only need to get it when they have moderate to severe symptoms or they're so ill that they need to be hospitalized. So I could say that we definitely do it a lot more here. But I'm not sure. I'm not sure what the effect of that is. It probably means that we do overprescribe antibiotics sometimes because, as I said before, even in viral pneumonias, you can have opacities. So those patients may get antibiotics, whereas if you hadn't done the chest x-ray and just treated as viral, they wouldn't have gotten the antibiotics. I don't know if you're worried about the radiation exposure. I think that's a concern, but the exposure from one chest x-ray is pretty minimal.
Dr. Kurian, just a lot of questions are coming through now. So the last two questions. So here's IK Patrick Leonard. Please, Dr. Jessica, my name is IK. What to know if blood test is also good to be used to diagnose pneumonia in children?
Oh, what blood tests are good?
Yes.
I think I don't know a lot about the lab test. I do know that I think the high CRP is like the most specific finding, but you don't need to obtain it routinely. You know, I think that the diagnosis of pneumonia is based on the clinical findings, the symptoms, and the physical exam, and maybe also a chest x-ray. I think the labs are usually drawn more to determine what the organism is, which we can't always isolate. But what I've read is that the high CRP is the most important thing.
Another question now, Lena Lambert. Thank you for the great presentation. We have not been using ultrasound routinely for examination of lung pathology. Are there any resources you can recommend for the technique?
Oh, sure. Actually, I have my email address at the end of the talk, but there are some articles about it. Definitely for looking at the pleura, it's a simple technique. all you need to do is we usually use a linear transducer, high frequency transducer, and we scan between the ribs and you go all around the chest from top to bottom. So it's a really straightforward exam. And if you're interested, I could send you a couple of articles.
That's it for now. I'll let you keep on going now.
Okay, so
interrupt again later.
Okay, so I'll keep on going. So I'm gonna go to my next case, which is a 14-year-old boy with neutropenia and fever. So here's a chest x-ray, and the patient has a nodular density in the right lower lung field. And if you look a little closer, there are other smaller ones in both upper lobes. So the patient had a CT scan, and now we can see there are multiple pulmonary nodules. Some of them are peripheral and they touch the pleura. And some of them have a little bit of central cavitation, like this one and this one. So this is a nodular pneumonia, and there's a differential for this. The two most important things, or the most common things in the differential, are septic emboli, which is caused by Staph aureus, and fungal infection, such as aspergillus and histoplasmosis. There are a lot of other things like bacteria, other viruses, and EBV, which can cause nodular appearance of pneumonia. But the top two to remember would be septic emboli and fungus. And this patient actually had septic emboli from MSSA infection. So in septic emboli, it's caused by Staphylococcus aureus, and it's secondary to some other primary infection, including right-sided endocarditis, thrombophlebitis, line infections, osteomyelitis, soft tissue infections, and periodontal disease. On imaging, you will see classically peripheral or subpleural nodules and wedge-shaped densities with cavitation. It has a predilection for the dependent and lower lung fields. And this is a different example. This is a boy who developed septic emboli after he had thrombophlebitis in his arm after an IV placement. And on chest x-ray, you can see there are multiple thick-walled cavities in both lungs. And this is seen also on the CT. So the next special group, the case with septic emboli was to transition us to our next special group, which is immunocompromised hosts. So there are two groups of immunocompromised patients. One are those with congenital conditions and other are acquired conditions. Congenital immunocompromise are the genetic immunodeficiency syndromes, and acquired causes are HIV/AIDS, malnutrition, and iatrogenic causes, including chemotherapy and organ transplants, including solid organ and bone marrow transplant. So immunocompromised patients are susceptible to many different types of infections, different fungi, bacteria, and viral, and I've listed some of the more common ones here. For today, since we don't have a lot of time, I'm just going to talk briefly about aspergillus. So aspergillosis, there are actually three forms of infection: invasive aspergillosis, allergic bronchopulmonary aspergillosis, or ABPA, and mycetoma, or fungal balls. In invasive aspergillosis, this is seen almost exclusively in neutropenic patients, including transplant patients and those on chemotherapy. The hallmark on imaging are pulmonary nodules. They can have poorly defined margins. They can have cavitation. The CT halo sign is when there's a ground glass halo around a pulmonary nodule. An air crescent sign is when there's air within the nodule shaped like a crescent because the center of the nodule is contracting. And that's actually seen during the immune recovery phase, so when the neutrophil counts are improving. And they can also have hilar and mediastinal lymphadenopathy. So this is a 15-year-old boy who had acute lymphoblastic leukemia and neutropenia. On his first chest CT, we see a nodule or mass in the left upper lobe, and it has a peripheral ground glass halo. So this is the CT halo sign. And then 2 weeks later, his counts are recovering, and now he has an air crescent sign. So there's this curvilinear portion of air, and the central part of the nodule is contracting. So this is an example of invasive aspergillosis. This is an 8-year-old boy who also had ALL and neutropenia. And as we scroll through his CT scan, you can see these innumerable pulmonary nodules, and many of them have ground glass halo. So this is another example of invasive aspergillosis. So my next case is a 19-year-old boy, previously healthy man with shortness of breath. And on the chest x-ray, he has very extensive bilateral patchy pulmonary opacities, more on the right than the left. And on his CT scan, it's basically the same findings. So very extensive airspace disease. Many of the opacities are peripheral and touch the pleura. Some of them are a bit nodular. And here in the right upper lobe, the opacity has ground glass attenuation, meaning it's not very dense so that you can see vessels running through it. And the central part of the ground glass is more dense than the peripheral. And this is another type of halo sign. And this is a patient with COVID-19 pneumonia. So I don't have a lot of time to talk about COVID-19 pneumonia, but I felt like I had to address it in some way, given the state of our global pandemic currently. So what I wanted to do was talk about the ways that COVID-19 pneumonia is different from the regular bacterial pneumonias that we used to see. And I don't know how helpful this is right now, but hopefully it will be helpful as the incidence of COVID goes down. So to start with, in COVID, the opacities are usually bilateral, whereas in bacterial, it tends to be unilateral. In COVID, it's multifocal or multilobar, whereas in bacteria, it tends to affect one segment or one lobe. Unlike bacterial pneumonia, COVID is predisposed to the periphery of the lung and the lower lung fields. And then there's some things that you see in bacterial pneumonias which have not been reported at all in COVID pneumonia. And those are round pneumonia, pleural effusions, and lymphadenopathy. So these are not hard and fast rules, but they're sort of some general features that might be helpful. These are 3 different examples of COVID pneumonia from our hospital system. So in the first one, we have diffuse bilateral ground glass opacities with more confluent consolidation in the left lower lobe. This is a different patient where we have opacity throughout the right lung. A lot of it is central, but some of it is peripheral, and the left lung is spared, which is a little less typical for COVID. And then in the last case, we have very extensive bilateral ground glass opacities. On CT, COVID is bilateral and multifocal. It predominates in the lower lobes, and as I mentioned before, peripheral and subpleural regions. You can see ground glass opacity and consolidation. You can see a halo sign, and tree and bud nodules have been reported. So these are 3 different examples. This is actually the case I showed you first, that I've already showed you, with the ground glass opacities in the right upper lobe that are more dense centrally. This is another example of a halo sign. This patient has a nodular opacity in the left lower lobe, and it's more dense in the center than at the edges. And this is just an example of a subpleural ground glass opacity. Now we have to make sure we know how to distinguish COVID pneumonia from multisystem inflammatory syndrome in children, or MISC, associated with COVID-19. So MISC, the hallmark on chest x-ray is pleural effusion. The opacities are always bilateral and in the lower lung fields. Other very common findings are cardiomegaly and intra-abdominal inflammation, usually mesenteric lymphadenopathy. So this is a 9-year-old girl who had MISC. On the first chest x-ray, she has these faint symmetric ground glass opacities in the lower lung fields, and her heart is a little enlarged. And on the follow-up 2 days later, we can see that the lower lung field opacities have progressed, and she now has bilateral pleural effusions, and she has cardiomegaly, and her heart is a little bit larger than when she came in. Okay, so to summarize the things that we've talked about the differences between bronchiolitis and pneumonia, imaging of pneumonia and complications, and special groups, which were TB, immunocompromised hosts, and COVID pneumonia. I want to round out this talk with a final interesting case. So this is an 8-week-old boy with cough and fever. I have a chest x-ray, and he's rotated to the right, but we can still see that there's a whiteout of the left chest. It's completely opacified. So the next step was to do an ultrasound. Now this is a very small child, and the question that I had answered earlier about how good is it for the central and portions of the lung. This patient is so small that we can actually see his entire chest. So what we see is that on the left, nearly the whole lung is consolidated. There is a pleural effusion. And when we look closer at the consolidation, this is how it looks. And you can see it's not that hepatization appearance that I showed you earlier. This one is much more heterogeneous, and it has a lot of hypoechoic spaces in it. I have a clip scanning through some of the consolidations so you can get a better idea. So you can see there are lots of round spaces. Some of them look quite cystic. There's also a pleural effusion, which is complex, and it has these fibrin strands which are flapping around. So this is a chest x-ray a few days later. And now what we have is that the patient has developed a large area of necrosis in his left lower lobe with these large irregular lucencies. And you can also see that he has a pneumothorax. Note that he has 2 chest tubes on this side, and that's because the pneumothorax was very hard to drain. It was refractory to the chest tube placement. So a CT scan was done. And as we scroll through, we see there's a pneumothorax with an air fluid level. And I'll play it again so we can look at the left lower lobe. The left lower lobe is replaced with all of these irregular cystic spaces, and that's due to cavitary necrosis. On the soft tissue windows of the left lower lobe, we see those lucencies, and we also see areas of decreased enhancement. And on a sagittal image, you can actually see a bronchopleural fistula between the left lower lobe and the pleural space. This is actually a follow-up. This was the chest x-ray at the time of diagnosis. So this patient did very well with conservative management. We see that the left lung is much more aerated than it was before. Most of the pneumonia has cleared. And when we look closer at the left lower lobe, there are these little round lucencies. So those are probably some small pneumatoceles. All right, so I've talked about the role of chest x-ray, ultrasound, and CT in the diagnosis and management of pneumonia and its complications. I just have a few take-home points. So remember that viral bronchiolitis is the most common lower respiratory tract infection in the 0 to 2 years age group. A chest radiograph can be used to rule out lobar pneumonia in equivocal cases. Ultrasound is important for identifying complications of pneumonia and guiding management. CT can be reserved for difficult cases. Remember the complications of pneumonia. They're divided into pleural and parenchymal. The pleural complications are pneumonic effusion and empyema, and the parenchymal complications are cavitary necrosis, lung abscess, pneumatocele, and bronchopleural fistula. The hallmark finding of primary TB in children is lymphadenopathy. The hallmark findings of invasive aspergillosis in immunocompromised patients are pulmonary nodules, ground glass halo, and cavitation. So the differential diagnosis of pneumonia, as you can see, in children, it's very broad. The things you can consider to help you narrow your differential are the age of the patient, the clinical presentation, immune status, and pattern of opacity on chest X-ray. So that's all I have. And here's my email address. And I'm very happy to get any questions from any of you by email. Thank you so much.
Any questions from the audience? Got one, another question here. What are the hints of distinguishing invasive aspergillosis versus metastasis? The first thing that came to mind when I saw that CT was metastasis. So this was from a while back.
I mean, I would say in children, putting aside the image, in children, you would need to know the clinical history. So, you know, if it's a patient that's neutropenic and febrile and has other signs of infection, you know, then you would go towards aspergillus. With metastases, you know, they would have to have a history of some kind of solid malignancy. I think in our practice, a lot of the cases of aspergillus we see are in leukemia patients. So, but sometimes you can't tell. I think if you have a halo and you follow up in a couple weeks and you see a cavitation, you can definitely lean more towards an infection. So when we're not sure, usually what we do is do a short-term follow-up. But there are definitely cases that end up needing a biopsy. I hope that answered the question. Oh, I think you're on mute, Dr. Nguyen.
Oh, yeah, there's just, can we please have Dr. Kurian's email address again? So yeah, that can go out to the audience again. And just a lot of thank yous and great lecture, many of those in the chat box. And so it says, excellent information, very good clinical cases.
Thank you.
Just many excellent presentations, great presentation. Thank you so much from all over the world. So a very good presentation. Thank you very much. So thank you very much for sharing. Great learning session. So thank you very much, Dr. Kurian. It looks like there's no further questions, but in the chat box, there's tons of thank yous and appreciation for your lecture.
Well, thank you so much. It's my pleasure.
Have a good day, everyone. There's Jose. You got something to kind of say here?
I just want to thank Dr. Kurian for doing this excellent presentation and for Health for All. We had a peak audience of more than 100, 150. And thank you, Dr. Nguyen, for doing this, for moderating. And to all of you out there, we hope we can see you next week. Have a great
day. You'll be able to kind of get the email address out again. I guess like the audience was asking, so.
Yeah, we're gonna upload the lecture on our YouTube channel so everyone can watch it later also, and the email will be there.
Thanks, Jose. Well, thank you, everyone. Thank you, Dr. Kurian.
Have
a good day, everyone.